Good afternoon, everybody. Thank you so much for joining us for Family Council's Ontario 2025 Innovation Summit. This is our last session of the week. So this year we tried something a little bit different for our Innovation Summit. We hosted one event per day for the whole week. Monday to Thursday, we've covered so many different and interesting topics. And today is the final one. This session is titled Better Experiences, Better Healthcare, co-hosted by Patient Ombudsman and Family Councils Ontario. For those who don't know me, hello, my name is Taeyang Zhang, and I'm the Bilingual Events Manager at FCO. So before we start, I would like to take a moment to recognize the land on which we are gathered today. I'm currently in Toronto, which is seated on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis people. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. So now a few logistic and housekeeping rules. I know that some of you have probably attended a lot of our events, so you know the drill. But for those that it might be the first time, you'll notice that everybody is in listen-only mode as this is in a webinar format. But you will have time at the end for an interactive question and answer period. So you'll see that there is a Q&A box, and I invite you to ask your questions to our speaker using the Q&A box all throughout the presentation, and we will get to it at the end, or if there are questions that can be answered by text, we will do that as well. And if you are more comfortable asking a question by audio, you can raise your hand. There is a feature, a React feature at the bottom in the menu, and you can raise your hand and I will give you the feature to turn on your mic if you are more comfortable asking a question by audio. And we also have a chat box. My colleague Yoan is putting a couple of welcoming remarks there. So you're welcome to use the chat box as well, just to share your thoughts, opinions, reactions throughout the presentation. And you'll also notice that today's session is currently being recorded. So we try to record most of our sessions to upload them on our YouTube channel so that if you want to view it again, or if you want to share it with someone that might be interested, or if somebody wasn't available to be present today, they can view it. So it will be available on Family Council's Ontario YouTube channel next week. So now it is my pleasure to introduce today's guest speaker. Craig Thompson was appointed Ontario's Patient Ombudsman on March 29, 2021, having first served as the Office Executive Director starting in 2017. The Office of the Patient Ombudsman receives complaints about experiences with Ontario's public hospitals, long-term care homes, and community care services, and community-based surgical and diagnostic centers. Quake has more than 40 years of leadership experience working in the public and private sectors of ombuds, healthcare, communications, mediation, and engineering. He is a recognized healthcare leader who is passionate about improving the quality, safety, and experience of healthcare for patients, residents, and caregivers in Ontario. Craig is active in the Canadian Ombuds community, having recently completed his third term as Vice President on the Board of Directors of the Forum of Canadian Ombudsmen. He is a certified health executive and registered professional engineer. Craig, the floor is now yours.
Thank you. Thank you for that lovely introduction. And I'll just share my screen and get past that first technical hurdle. And let me know when you see the slide.
Yes, perfect. Thank you so much.
All right. Well, thank you. This is always a bit of a treat for me to be able to speak to the family councils of Ontario. And then mostly because I am a family member. I have a family member that was in long-term care. And so I come to this work with not only my professional hat that I wear, but also my own personal hat as a son with two parents that have experiences with long-term care homes. So it's important that my office makes itself aware to family members and caregivers who support their loved ones in long-term care so that if it turns out that there's a circumstance that we can help, that you know where to turn. And that's really what I'm hoping to be able to pass on today is just enough information so you know whether this office is the right office to be coming to. But always with the caveat that if you're not sure if we are an office that could be helpful, to you or your loved one, then please reach out because we're happy to answer questions and always there either by phone, online, whatever is the most comfortable way for you to communicate with us, we're there. So I call this session Better Experiences, Better Healthcare because that is fundamentally how we look at the office and its mandate. We are very unique in the fact that we look at experiences of healthcare versus more the clinical side. So we look at the experiences that Ontarians are having in the various healthcare settings that we have oversight over. And the fundamental driver for that or goal of that is by understanding the experiences and making sure those experiences are as good as we can make them, that we will have better healthcare ultimately. So that really is a bit of our goal, our mantra that we want to make sure that the experiences people are having in Ontario with the various healthcare settings that we have, that they're as good as and excellent as possible, because ultimately that's going to lead to better healthcare. So just off the top, in terms of this office and what is an ombudsman, many of you may not have actually had an experience with an ombuds office. And that might be a good thing because generally ombudsman offices operate in the same way in that we work with complaints. We work with individuals who have had experiences with various government agencies, and those experiences were not as intended or didn't go as well as were expected. And so there's a complaint or an issue that has not been resolved. So as an ombudsman's office, we are quite, we operate very much like all ombudsmans across the world. And there are thousands of ombuds offices in the world. And we all are fundamentally in the same business of trying to ensure that people who access government services or public bodies are treated fairly. It's a simple concept, a little bit more complex in terms of how we actually get there, but that is ultimately what an ombudsman's office is. Anywhere, anytime that there's been public money is being spent on a service and there are citizens getting that service, whenever there's a problem, it arises in the delivery of those services. Ombudsman's offices are there to help resolve those. We are in the business of promoting fairness and accountability in public administration. So we know that government services, for all their best efforts, can sometimes be complex. Sometimes the circumstances of the individual are not really taken into consideration in how those services are provided. And that can give rise to issues that don't either allow that person to access the service in a fair way, or that the public body is not accountable for any failures. So that's really fundamentally the work of an ombudsman is in that promoting of fairness and accountability. And we also operate while we're funded by government, we operate totally independent of government and we are impartial in our oversight. And when I speak about impartiality, particularly in the context of the Patient Ombudsman's office, that means that we are not advocates for one party over another. So we're not an advocate for the patient or the resident of long-term care, and we're not an advocate for the organization or the administration. And we're certainly not an advocate for government. We are very much independent and impartial and provide our oversight through that lens, so that when we come to a decision that we feel um, is fair and reasonable, is a decision that we've reached independently and impartial. So those are the key features of our work, that independence, impartiality, and confidentiality. Confidentiality in the context of a healthcare ombudsman is really important because we're dealing with personal health information, and that's very important that we maintain confidentiality. And but also confidentiality is a way, an important aspect of how we build trust, not only with the individuals who come to us with a complaint, but also the organizations we deal with. And then we operate, like many ombuds, through legislation, through a statute, and that's those statutes give us our jurisdiction. So, what organizations do we have oversight? Who we're accountable to, and what powers we have as an ombudsman's office to be able to do this work. So, just really quickly about what's unique about the patient ombudsman. And what is unique is the fact that we're solely a healthcare ombuds. So there are many ombudsmen within Canada who have multiple jurisdictions, of which healthcare can be part of that jurisdiction. And Ontario, we're unique in that way, in that the large portion of the Ontario healthcare system is within the jurisdiction of the patient ombudsman and the other jurisdictions of other government services that are delivered through the ministries of government are under the Ontario Ombudsman. So patient ombudsman is unique, not only in Canada, but unique in the world, in that we are solely focused on health and healthcare organizations. So that means that all day, all the time, we think about healthcare. We work with healthcare organizations. We talk to residents of long-term care. We talk to patients. We talk to families, always in the healthcare context. We also do all of our research in the area of healthcare. Our interests are in the area of healthcare. So we really are, I think, as a team, highly devoted to the healthcare sector. Some of us come from healthcare backgrounds, not always, but we very much focus on that, and we feel that that brings some credibility, certainly, to the work that we do. But it also allows us to be able to look for those resolutions and solutions to issues that are in the Ontario context or in the local context, because it's really important to recognize that everybody's concerns are unique, and so the resolutions to issues will be unique. So we're entirely focused on healthcare. We're also committed to whatever we learn in terms of working through challenges that people are having within the long-term care sector or the other sectors, that those improvements to quality are not only experienced by the individuals, but also by the whole sector. So we do a lot of work not only resolving complaints, but also making sure that those complaints or resolutions are documented, and that we share that information with the organizations that we have oversight and that we feel could benefit from what we've learned. So we capture those unique perspectives in those complaints for the purposes of quality improvement, because that's what really puts meats on the bones of the idea of better experiences, better healthcare. Through the experiences, we learn what works, what doesn't work, and then ultimately, if we can share that with other organizations, we will get better healthcare. And as I said, we are very much focused on the individual experiences of residents of long-term care and their family members. But we know that there is some common themes that we can come across in that work that could be beneficial to not only other residents in a long-term care home or the entire sector of long-term care homes. And so we're really focused on getting to resolutions that could result in better experiences. And what does that? How do you do that? It can be an update in a policy or a procedure. It can result in more training for staff or some education for family members or residents, and just generally improve processes overall. We also do investigations, which are a very special kind of resolution to a complaint. It's much more formal. We do about 6 of those a year because they're much more involved. And then through those investigations, we can actually make recommendations to an organization as to how we feel the gaps that we've identified can be filled. And then those recommendations we can be public about so that we can look to all organizations learning from that circumstance. So just really quickly about how we came to be and what defines how we function. For those of you who have an interest in healthcare policy, there's a piece of legislation called the Excellent Care for All Act, which in 2010 created the concept of an ombudsman in healthcare in Ontario. And then in 2016, our offices opened and our first ombudsman was appointed, Christine Elliott, in 2016. And so the office then began its work. And that piece of legislation gives us the responsibility to receive and resolve healthcare complaints. It also allows us to conduct investigations and to make recommendations to healthcare organizations in order to achieve that broad system change, and also serve as what is often referred to as an office of last resort. And I'll touch on that quickly in a subsequent slide. The vision of this office is quite simple. We want a healthcare system where everyone is treated fairly. It's a very simple idea, sometimes a little bit more complex in trying to achieve it, but that is the vision. And we do that by dealing with individual complaints, sharing information, making recommendations, and making sure that the experience of one person has the potential impact of improving the experiences for everyone. So in terms of who and what organizations we have oversight over quite a large swath of the Ontario healthcare system. So all public hospitals, of which there are 140 public hospitals representing over 300 sites across the province, all long-term care homes, of which there are 630 approximately, a mix of municipal, not-for-profit, and for-profit long-term care homes, and that constitutes about 80,000 and growing beds in the province. Home and community care, as it is delivered and coordinated through Ontario Health at Home, so that represents about 14 home and community care support service organizations, and some other community agencies that provide home care services. And our newest jurisdiction, which came into being in just September of 2023, so we're coming on 2 years with this new jurisdiction, is the community surgical and diagnostic centers, of which there are 900 and growing. And these are the centers where you'll get X-rays, CT scans, certain kinds of non-invasive or minimally invasive surgeries, cataract surgery. They are now under the jurisdiction of this office. So it's a very large part of the Ontario healthcare system. But what is not within our jurisdiction, which doesn't mean we don't get complaints about it, is the family doctors or the primary care sector is not within our jurisdiction. And we did and do get quite a few complaints about those challenges within primary care, recognizing that there are certain challenges with individuals not having access to a family doctor. So we will get those complaints. And we do our best to refer them to the proper organization that can help them with it. But we also don't have oversight over public health facilities or walk-in clinics, things of that nature. Again, if we do get a complaint about those facilities or those sectors, we will do our best to refer somebody. I guess one of the other areas that sometimes is unclear in terms of oversight, we do not have oversight over the regulated healthcare professionals that work in the Ontario healthcare system. So I'm talking about the doctors, the nurses, occupational therapists, and so forth. So any complaint about those individuals, about their professional conduct or their clinical judgment goes to the regulatory colleges, of which such as the College of Physicians and Surgeons, and those colleges will take those complaints. But as always, the caveat I put on this, if you're not certain if we're the office that could assist, please give us a call, and we're happy to answer any questions that you've got. So I touched on this idea of being an office of last resort. Again, this is not unique to our office. It's all ombudsman offices operate in this way. And really, what it means is that when someone has an issue with delivery of care, the complaint should be raised with that organization first, because ultimately that's where the best resolutions occur, is when you're actually dealing with the organization that has the ability to make the changes in that moment, or through their own policies and processes to make sure that that complaint or issue is addressed and doesn't happen to another individual. And so that's really the first place to always start. So when it comes to long-term care, the complaint that you make should be made with the director of care or with the registered nurse to make sure that it gets officially documented as a complaint. You obviously, again, speaking from my own personal experience, there's always circumstances where in the services provided to your loved one, there can be things that don't go as well as you'd like, and you can talk to PSWs and try to get to a quick resolution in the moment, or speak to the nurse on the floor. But ultimately, if you're experiencing challenges that just don't seem to be addressed or taken seriously, or you really feel that there's a benefit that could be gained by more residents in the home than just yourself or your loved one, then raise it with the director of care, so that it's officially recorded, and you can go through the formal resident relations process to get that complaint resolved. But if after that is done, and you've made your best efforts, and the organization has made their best efforts to get to a resolution of your complaint or issue, and you're not satisfied, or someone's not satisfied in your family, then that's where an ombudsman office comes in. It's also dependent on if you've also exhausted or tried to get some benefit from speaking to the family and residence hotline. That really is the sort of second tier to resolving your complaint. So if you're not happy with how the home is responding, then call the resident and family helpline. They have access to the inspections branch folks if there's something that speaks to quality of care issues. If at that point you're still not satisfied, then the patient ombudsman's office is the place to come. So a little bit of what we do and what we don't do. So we are certainly an organization that relies on facts and fairness, rather than fault. So when we looking to seek a resolution, we will gather evidence in terms of gathering the facts and understanding what has transpired by listening to both the complainants and the organization. And we'll be looking to make any kind of decision based on that evidence, but not looking to always for fault. We're looking really to seek a resolution where there's a benefit that comes for all parties in terms of getting to that a resolution for that complaint. We don't share personal information with organizations until we get the consent of the complainant that came to our office. So if you're a resident of long-term care, or you're a caregiver and you come to our office, and you share information about a particular situation, we will not share that information without your consent. And so that's really a way that for us to build trust. We will, if we're not the organization that is in the best position to help. So if you may have come to us maybe a little bit early, and not access the services of the ministry's hotline, or the inspections branch, which may be in a better position to actually resolve the complaint that you've got, then we'll refer you to them and make sure that you get connected back with them. If in some circumstances you're not aware even of the complaints process within your long-term care home, or maybe the name of the director of care in that home, then we're happy to provide that information to you so that you can get connected. So we do our best to do that referral to the right organization, and facilitate that as what we call a warm handoff. Try to get you to exactly the person you should be talking to. And again, always encouraging you to call us if you have any questions. Some of the things that we don't do is we don't accept or investigate every complaint we receive. Sometimes we get complaints, and I've talked about them, that we just can't deal with because it's not within our jurisdiction. So we would be going outside the boundaries of our mandate if we did that. But there's also sometimes we get a complainant coming to us who's looking for a resolution that we just can't achieve. And for example, sometimes they'll be looking for monetary restitution for an experience that they've had that was negative. That's not something that we can achieve. So if that's really what they're looking to get out of a resolution, and we know we can't get that, then we wouldn't accept that complaint. Um, Also, when it comes to referrals, we don't actually make the referral on your behalf. We will provide the information and if it's helpful, connect you through a warm handoff to an individual, but we don't actually take your complaint forward to another organization. One of the things that also, I'll need to understand, and this is for all ombudsman's office across Canada, is that we can't force or compel a health organization to act or adopt a suggestion or a recommendation. That's just not the way ombudsman's offices work. We're very much in the business of making suggestions and recommendations based on our experience and knowledge of legislation, of policies, of best practices. Um, and hopefully organizations would recognize that this is coming with an idea to improve, and they'll accept it based on the merits and the evidence that we present. We also do not give legal advice. We are not a legal process in any shape or form. If someone is seeking some kind of legal resolution, some or access to some sort of legal mechanism, we can make referrals to organizations like ACE, but that is not what this office does. We will not give legal advice. And as always, we don't take sides. Again, we're impartial. We don't advocate for one party over another, but we do advocate for a fair, impartial, and unbiased process. How do you make a complaint? I've talked about you being able to call our office. That's where we get most of our complaints is when people call us. So we have a Toronto number. We also have a toll-free number. You can go onto our website. There's quite a bit of information on our website to help you understand if our office is the place that you may want to reach out to help you deal with the concerns you have for your loved one or for yourself. You can also email us at info@patientombudsman.ca. But primarily, the way that people get to us is through our phone number. So we have a call center that is open 5 days a week, and happy for you to call. We also can receive complaints or inquiries by mail. In not so many cases today, but now that we're post-COVID, but if someone feels an in-person appointment is really something that is appropriate, and something that we can organize, we will do that as well. And we still have a fax machine, so if you do still have a need to send us a fax, we can manage that. So our office is about 26 people. We have English and French speaking staff. So if that's more comfortable for someone to work in French, happy to accommodate that. We also have simultaneous translation services. So when you contact us and you identify that you would like to interact with us in a language that is more comfortable other than English and French, then we're happy to arrange that. And if you're an Indigenous complainant, we do have resources that are available in 6 Indigenous languages. And we have other resources that are available in 22 other languages. So we will do our best to accommodate anybody's unique circumstances because we want to make it as comfortable and safe a process for you to be able to make a complaint to our office. So as an ombudsman office, we are required to report on an annual basis what it is that we're hearing from the various healthcare sectors that we have jurisdiction over. And so in our annual report that we just released in the last 10 days, we talk about all the different things that we hear about in complaints, what kinds of investigations we've undertaken. But it's really one of the most important ways that we have of making sure that the government, that the organizations that participate in the Ontario healthcare system understand what patients, residents of long-term care, family members, and healthcare providers are telling us about what's not working in the healthcare system. And it's always, again, not from the standpoint of naming, blaming, and shaming. It's really from the standpoint of learning from things that haven't worked so that we can improve the experiences for everybody. So we're always in that listening, learning, and leading mode. We are intense listeners because we have so much to learn from the experiences of residents of long-term care, family members, patients. We want to be able to take what we've heard and learn from it, and learn by applying not only what we learn from complaints, but what we come to know about how hospitals, long-term care homes operate, what works, what doesn't work, how things work maybe in the north better than they work in the south, and vice versa. So we want to take that learning and add it to the significant insights we gain from residents of long-term care, their family members, and patients. And then we want to lead with that by making sure that we talk about it. And so this is what this report is about. And I'm going to give you some of the high points of some of that data that we just shared recently. So in terms of numbers of complaints, everyone's always interested in this number for different reasons. I'm always encouraged to see more complaints every year because that means that the awareness of the office is growing, and more residents of long-term care, their family members, and patients see us as a opportunity to try to get to a resolution for an issue that they've had with a healthcare experience. And so for me and my office, more complaints is a good thing. What we do not want to see is more complaints about the same things. And so that's something we talk about in our reports is, what's new, what's a new evolution or a new issue in the healthcare system. But we'll also talk very much about what we continue to see, because that's really where we recognize that things are not going as well as they should be, and we're not learning from our experiences. So we're doing about 5,000 complaints a year. We started when we opened our doors at 1,500, so we've been growing significantly ever since we opened in 2016. And I said we get predominantly our complaints from the call center, followed by written complaints through our website or through mail. And who contacts us? Well, most of our complaints, 54%, come from residents of long-term care or patients in hospitals or receiving home care. So that's the people receiving the care are the people who are complaining about the care. And that number has not changed pretty much since we opened. But then very quickly on the heels of that, it's the family members, it's the caregivers who are the ones then that contact us. So the daughter, the son, the parent, the guardian, the spouse, they are then the individuals or other family members who then speak to us. So caregivers have a big role to play in advocating for their loved ones who are getting care, but also being the ones that have the responsibility to make the complaint on behalf of their loved one who's getting care, so that we are made aware of things that did not go well, and we can try to seek a resolution. We do receive complaints from people who seek not to identify who they are. They are sometimes referred to as whistleblowers. So it could be just an individual who just, doesn't really want to get involved with a complaint resolution process, but they just want to make sure that we heard about a bad situation. We will take that information as well. We do recognize that there are some people who really are concerned that if they did complain, it would affect their delivery of care. And so we're recognize that, and we're always hoping to make the experience as safe and comfortable for people so that that does not happen. But we know that that can be something that people are concerned about. And we also will hear from healthcare providers who, because of the nature of their role in an organization, choose not to identify, but do want us to be aware of a particular circumstance. So they also will give us calls. And we get complaints from all over the province. We this year we are looking at this from two sides of the same coin to try to understand better who is complaining. So predominantly our complaints when we adjust for population come from the Toronto region, and then it's followed by the north, west, east, and central. And so that's pretty classic for us in terms of Toronto is where there's more hospitals and healthcare settings. So it makes sense that you're going to have more complaints about those organizations. But when we look at who is complaining in terms of where is the complainant from, and that data is a little bit difficult for us to access sometimes because we only ask a complainant for their own personal location when it's required. So we're not always asking people, where do you live? We certainly need to know where they got their care. But when you look at it from this standpoint, we are seeing that people who live in the north actually have more complaints. And so when you couple that with the two charts, you realize that the North, people in the North, not and organizations in the North have a higher number of complaints than most, and they have more issues that they raise complaints about. So we know that that just speaks to the challenges for residents of long-term care who live in the North, those organizations that serve those residents in the North. We know that there's more complaints in those regions. And then by sector, we get most of our complaints from hospitals. It's always been the way. The hospital sector is just that much bigger a sector than the other three that we have jurisdiction. We also get quite a few complaints that are about programs or services outside of our jurisdiction. So we do get those complaints. We do try to give as much information as we can from a referral standpoint. But then it's followed by home and community care, long-term care homes at 7%. So again, not much of a change since we opened our doors. Those sectors are just that much smaller. And then followed by community surgical and diagnostic centers because it's our opinion on why it's at 4% is because it's just such a new sector to our office, and people aren't quite aware that the Ombudsman is a service that they could access. The caveat that I always put on this number for long-term care homes at 7% is I think behind that is a concern that people who are in long-term care, because it is care that is delivered in your home, if you live in a long-term care home, you are more reluctant to complain because you have a concern that it may impact your care. And so that's it can be a real concern. So we recognize that probably it keeps that number down a little bit, but we do know that behind that 7% of complaints, there are many, many more residents and family members who are experiencing similar things. And then in terms of what do people complain about, we take every complaint and we listen to every story, and then we start teasing out what we think are the issues, and talking with the complainant to make sure that we understand the issue. We have a whole syllabus of categories of complaints that we begin to use to allow us to be able to talk about it and be able to report on it. But generally, and this is across all four sectors that we have jurisdiction, quality of care is the number one complaint, and that would make sense because these are healthcare settings. Care is the number one service that is provided, and when there's a breakdown in that care, it's the quality typically where that happens, and so that's why it's number one. But one of the other types of complaints that we get in the top 10 is always communication. Healthcare is very much a communications business. There's a lot of information being shared. These are intimate, important relationships that people have with their providers, and so there's a lot of information, a lot of discussion happening. So when communications breaks down, then that leads to problems in all areas. So communications can cause problems in quality of care. Bad communications can cause problems with how you get discharged or transferred to another care setting. It impacts everything. So communications is really a significant aspect of the problems that we deal with. So I'm just going to talk a little bit Um, I provided this slide just so you get a sense of the other sectors, what the complaints are. Um, just going to drill down a little bit on long-term care homes, and particularly the top five complaints and what they look like. So when we talk about quality of care in the context of a long-term care home, this can include substandard care, where care is not delivered at the appropriate time in the appropriate way. It could mean that there could be poor pain or symptom management. It could be that the skin care or wound management um, processes are not what they need to be. We did identify in this annual report specifically, and this was in long-term care, but also in the hospital sectors and home and community care, that skin care and wound management is an area that there are more challenges. And so we are identifying that as a trend that we're seeing. We're trying to understand better how it's manifesting itself in the different sectors that we have jurisdiction. But that is something we have identified is occurring and on the rise. And that is a big quality of care issue and concern for our office when we hear those complaints. So when we talk about communication in the context of long-term care homes, um, a lot of times that can be a breakdown in communication in terms of the sharing of information with family, so that the family is fully aware of the circumstance, that the information that an organization or the provider needs to be able to provide appropriate care for the resident needs to be shared by the family, and those opportunities to have those family council meetings and consultations needs to be in a way that that communication can flow. So breakdown in communication it can be a challenge. We do certainly hear about cultural and language barriers that occur within homes. Unfortunately, there are residents in homes where their most comfortable language that they want to converse in is not the language of the home, and so there can be sometimes difficulty getting interpretation services and so forth. Also, from a cultural background, we all have our cultural norms that make our life comfortable and familiar. Food is one of those things, and sometimes we will get issues around language and cultural elements that are just not making it the most ideal experience for somebody in care. Also, sometimes, again, thinking of long-term care, residents or family members don't feel they've got an appropriate opportunity to ask questions or to get information. Maybe not feeling like they've been included in the care planning, or that there's been a delay. That can be a communication issue. So that's just how some of the ways that complaints about communication come to us. When it comes to complaints about abuse and assault, this is again obviously very concerning. It is something that we have seen arise since we started tracking this type of complaint. And this is any type of report of a verbal, physical, sexual, or financial abuse or assault of a resident, of a caregiver, or of a provider or staff member. So it covers a lot of different individuals, a lot of different scenarios, but it is something that we are very aware of and take obviously very seriously, and do have quite a bit of experience dealing with these very difficult and challenging types of complaints. But that is certainly a complaint that we do get. In terms of discharge, transfers, and transitions, anytime someone is moving from one care setting, so like from a long-term care home to hospital for some treatment or procedure and then back, those can give rise to some problems. Sometimes those things can occur late or be poorly planned. Sometimes it's inappropriate in that they didn't really understand the individual's unique circumstances, so that it maybe was unsafe in terms of how they did the discharge because of high needs patients not getting the care that they needed. It can manifest itself in many different ways, but that's what's we hear in this area of discharge, transfers, and transitions. And then finally, personal security and safety. What is covered under this is falls, falls prevention or lack of falls prevention, sometimes accidental injury when there is a fall, um, or the environment that in a long-term care, in terms of the physical environment, is not safe and puts people's health and safety in jeopardy, and that can also be for staff as well. So failure to provide that safe environment, that's some of the things that fall under that personal security and safety standpoint. So that's just some of the kinds of complaints that we would get from the long-term care sector. It's certainly not all of the types of complaints. Everyone's circumstances are unique. Every home is unique. And so we always make sure we listen to the entire complaint to understand it, recognizing that within that unique experience that someone's had, there's something that needs to be addressed to the satisfaction of that individual, but hopefully there's something that we will learn in that process, and the provider will learn that will benefit all residents in that home or all residents in long-term care within the province. So that's very quickly an overview of this office, and the types of work that we do, hopefully the service that we can offer you. And I hope I didn't go too quickly and I didn't speak too quickly. But as I said a couple times, if you had questions, if there was something that I said that was unclear, please give us a call. Happy to speak with you, or your loved one, to make sure that if there's a negative experience you're having, if there's something that we can do it to help you out, we'll do our best. So with that, I will stop sharing and happy to answer some questions.
So there's a few questions in the Q&A box, Craig, if you want to open it.
Okay, got it. Yeah, so I've been reading, is it Patricia? That question? You are, I immediately, you're right on. This is a serious issue, and I can speak to this from a personal experience, of having, um, my mom having to go into emergency room from long-term care and having to experience the challenges that come with the fact that she had dementia. So it is a very challenging environment at the best of times, but certainly very challenging for a caregiver and your loved one when dementia is part of that. So there is a lot of attention being paid by hospitals um, about dementia in the settings of emergency departments. There are dementia protocols. There is a quality standard now for how hospitals should be um, creating the proper environments, tailoring the experience to be able to address the concerns that come with someone who's suffering from dementia. It's not. I certainly know that we continue to get complaints about this. Some organizations are better than others of getting that information, changing their protocols and processes, and training their staff than others. So it continues to be a challenge, but there is certainly a lot of work that's gone into, first of all, understanding how it manifests itself when you are in a very challenging environment like an ED with the bright lights, the noise, the sometimes you're in a gurney in a hallway. It's all foreign from an environment standpoint to people. One of the things and you probably know this, that even without dementia, people, and it's not just seniors, anybody who goes into an emergency room can begin to have issues and cognitive issues just because of the environment. Typically, they're unwell, so that starts the process. But because of the lights, because of the noise, because of the activity, people can begin to decompensate. And so I would say that for everybody, there's something to be learned and to be gained by making sure that EDs are made more appropriate, not only for people who are suffering from dementia, but people in general, because they are very, very challenging environments. I hope that answers your question. Should I just continue going through the?
Yeah, I feel like, oh, there's a question that just came in from Linda. I can read it. Better communication and directions in large hospital centers for persons arriving and being sent on a long trek to the appropriate room with a treatment or test. Too much confusing science. Suggesting a wage type program for each setting in hospital to specific areas.
Thanks for that question, Linda, or comment. I agree. Again, hospitals are really challenging environments, particularly large teaching hospitals, where you've got a lot of you can have your emergency department in one wing of the hospital, and you've got, diagnostics and imaging in another area. Heaven forbid if there's a construction going on and you're having to like weave your way through a hospital. Um, if I had the answer to how you do a better, it sounds like there is a ways type program that does a better job of this. Um, uh, then I think it would be great for hospitals to adopt this. Again, in terms of complaints about, I'll call this navigation generally, it wouldn't be a big. We do not get a lot of complaints about people finding their ways through hospitals. I think it's just a common experience we have. Um, but if we did get a complaint, thank you for pointing out to me this Waze type program. We do always research things when we're looking to make suggestions to hospitals, or look to what other hospitals are doing that might be something that they could adopt, or look to a peer to learn from. So yeah, this has always been a challenge. Hopefully, it gets better with newer hospitals. But yeah, thank you for raising that issue. Lynette has a question. Have you ever received a concern regarding care for resident under public guardianship? Yes, we have. Um, some seniors have no one outside of the home to advocate for that care. If the resident has dementia, is it that much more? It is that much more concerning because they don't advocate for themselves. Just wondering if you have any examples of this and how the office might have responded. Um, so it's not a lot of complaints for sure, but we do sometimes have situations where a resident is under public guardianship. From a standpoint of our office, in terms of our own knowledge and understanding of the challenges in this, when this is we've had the public guardianship folks into our office I think at least once, maybe twice, to give us training as to what the public guardian folks provide, what the services are, there's a lot of issues around consent, because they have when you're under guardianship, the consent for personal care, the consent for housing, consent for financial decisions are important for us to understand exactly who has those consents to keep that individual safe, and recognizes what the law demands of us. So we, as an office, uh, do our best to stay on top of what it means when we come in a situation where there's a public guardianship in place. And in terms of how we might respond, I can't speak to one specifically. And another reason I couldn't speak to one specifically, we have so few of them, it would be almost impossible for me to relay the circumstances of a particular complaint without potentially identifying the individual. That's the challenge when you have a complaint of that nature, and there's so few of them that you really can only talk about them in the most broadest sense.
There's a
Oh,
few
Linda's
minutes
comment.
left. Oh,
Yeah,
yeah.
it's a good name of a program if you could call it Ways.
There's a few minutes left. If anybody still have any question, is there anything, Craig, that you would like to say to sort of wrap up as we wait for maybe last minute questions to come in?
Yeah, just I did a bit of a misspeak at the top. I tried to correct it, but I want to make sure it was clear. When I talked about when you've got an issue within long-term care, either you're a resident or you're a family member, um, when you speak to like you have an issue and maybe you're visiting and you speak to a personal support worker or one of the staff. That is not actually the official an official complaint in the context of kind of the legislation. We always will, things you can make a comment and someone will address the concern and that's the end of it. But if you actually have a concern for your loved one that you want to be, make sure that it gets documented and that the organization is certain you've got it. Then speaking to the nurse on the floor or to the director of care. That way, it certainly gets into the sort of the official process. If you're not happy with how the home has responded to that, then the second step is to talk to the ministry's helpline for families and residents. The name has changed, but it used to be called the hotline, but that's through the Ministry of Long-Term Care. Uh, Calling those folks it's also how you get if there's something a concern you had for maybe something that falls within the inspections branch in terms of maybe cleanliness of the facility or how something was done. They also can access the inspections branch for an inspection of the home and so forth. It's after you've exhausted those two um, first sort of frontline complaints processes that you come to our office that we can take the complaint and it's not premature to us. That said, there are circumstances where a resident or a family member may not feel safe or comfortable speaking to the director of care or the nurse or the ministry's helpline, and that you are still free to call our office and we will do our best to assist you.
Great. Thank you so much, Craig. We're getting a lot of good comments in the chat box. So thank you so much for this really insightful presentation. If anybody has any questions that come up, you are welcome to contact Patient Ombudsman. The contact info was provided at the slide, in the last slide, I believe. They're also in the chat. Or you can just connect with us, Family Councils Ontario, and I can forward your questions and your messages. And yes, so thank you so much, everybody, for being present today, for being so engaging. And if you have attended all of our events this week, thank you so much. Your support is really important, and we wouldn't be able to bring all of these sessions if it wasn't for your interest and your participation. So we really appreciate it. And as I mentioned earlier, this session has been recorded, and so have all of our sessions this week, and it will be available on Family Councils Ontario YouTube channel next week, so you're welcome to view them again. We do have one more event before we wrap up the year. It is on December 10, Wednesday, December 10 from 12 to 1. It is called Citizenship and Wellbeing in Long-Term Care, co-hosted by CARB Ottawa. So this is our last event of 2025, so we will be very happy to see you there if you are interested. Registration is published. And yes, so thank you so much for your continuing interest in our programming. We are working on the first half of 2026, so we will be bringing you even more interesting content, diverse content as well. And we are happy to continue our collaboration with Patient Ombudsman. So we're looking forward to seeing where this could go next year. So thank you so much, everybody, and have a good rest of the day.